Thank you, everyone, for taking some time out of your day to join us. Like Stephanie said, my name is Eric Ermie, and I'm the Director of Client Solutions. In a previous life, I was the Program Manager of Assessment and Evaluation at The Ohio State University College of Medicine, and a lot of what I'm going to talk about today stems from my experience using ExamSoft at Ohio State and some of the really cool things we were able to do. With that, I'm going to take you through a couple different things today. One, I'm going to walk you through the process of kind of how you can use what we can do for you as a software to identify things in your curriculum to study, and how you can start to look for things in your unique situations that will help you identify areas that could be potential board predictors for you. Additionally, I'm going to take you through my story, how it worked, what our results were, what interventions and things like that we were able to do. We'll go through your questions, and we'll also kind of show you throughout the way how ExamSoft fits into that whole thing. So where do I start? There's a lot of different ways that you can try to predict how your students are going to perform on the boards. There's a lot of different ways, a lot of different data points, a lot of different thoughts and historical things on how this should be done and how this could be done. And there's just there's such a vast amount of information out there in today's age about our students that where do you start with looking for what could start to predict for you how your students are going to do on the boards, or predict who's at least the most at risk to fail? Is your current method actually something that is predicting as well as you need it to and as well as you'd like it to, or is it something that you need to find a better way because it's not sensitive enough? And that was our case when we started looking into this. There's no easy way to do this. Identifying the criteria can sometimes be a long and arduous process, but you got to start somewhere. So with that, what we recommended when we started, after we did this and after we started trying to help other institutions do this, was look at what's unique. What is unique about your particular licensure exam? What is unique about your curriculum? Frequently, when it comes to licensure exams, question types or styles of questions are maybe uniform. The entire exam is one type of question or one style of question, or every question meets certain criteria on that exam. That can sometimes be a unique thing because most curriculums aren't like that. Also, what kind of domains are your board questions or your licensure exam going to cover? Is it mainly higher level application and synthesis type questions, or is it some recall, a couple of application questions, things like that? And how does that compare to your curriculum? Also, your curriculum might be broad, and to really educate your students the best, you've determined that you need to touch on a lot of different things and put a lot of emphasis across a spectrum of different topics and content areas, that you don't want to just teach to a test. You want to teach your students how to be the best physician, best nurse, best dentist, whatever it might be, the best something possible. And to do that, that maybe means doing the education differently than just tailoring it to the boards at all time. But your board exam might have some more specific content focused areas that's really all they're going to focus on, and your curriculum focuses on a lot more things than that. So finding those things that are unique about your board exam, or areas where your board exam and your curriculum might be slightly in conflict, can at least tip you off on where to start looking for what to study. What are your strengths? Sometimes you've got a rock star faculty member, somebody who just writes incredible exams, great questions, really gets how to get to that deeper level of knowledge of a student, where they're writing a question that doesn't just assess the cursory level things that the facts the students might be remembering. Instead, it's really getting them through a multiple step type question where they're applying and synthesizing information, and they're able to do that in a way that's very relevant to the content they're covering. Well, if you've got a rock star faculty member like that, maybe you want to start isolating them and taking a look at performance on their items, because that might start leading you in a direction, or it's an area to at least start looking at when trying to find areas to predict. Just like rockstar faculty, you might have just certain content areas in your curriculum that you feel stand apart from the rest. Maybe you're particularly known for your cardiology block, or maybe you've got a few professors who are particularly strong at something. Maybe you've got an entire department that is just world class, and not that the rest of your curriculum isn't good as well, but they really set themselves apart. Areas like that can be areas that, if you look into them closer, can start to help you identify a criteria that would help you predict how students are going to do on the exams, or that are going to help you isolate the students who are at risk of failing better than just general data would. So what do you have and what do you need? So the more comparison data you have, the better. You need as much data as you can, because you're going to start broad and start to try and whittle this down. Class rank by results by overall performance in your program, board results for previous year students, category performance data, those things, and lots of different versions of those things and different slices of those things are very important as you start to do an analysis like this. Also, if you don't have the data you need to compare, you got to take a step back and say, what do we need? What are we not looking at? Go back to those areas that might be unique about your curriculum and some of the things I was highlighting a moment ago and say, how can we turn those unique areas into data? Well, let's develop a categorization scheme for our questions. Let's base that categorization scheme on the areas we really feel like could be unique areas for us or could be predictive areas for us. And then use that standard categorization scheme across all your courses and blocks. Now, in my opinion, the best categorization schemes hit everything from the administrative clerical end to the very, very detailed specific learning outcome for a course end and everything in between. So you don't have to use everything identical across all the courses and blocks. Learning outcomes might be very specific to a specific course, and that's not something that you're going to be able to use in a different course. That's totally fine, and there's still great value to tagging those categories of questions. However, if you can at least use some common board subject areas or some cognitive domains or question types, at least a few areas that regardless of the specific items in different courses that are unique, those are the same categories used across multiple courses, you can start to be able to get yourself to a bigger data pool that'll help you hopefully find better results. The other thing is score prediction versus failure prediction is two different things. And depending on what you want to do, different analysis is going to work better or worse for you. And this actually ended up being the case for us, as I'll get into when I show how our story went. But what metrics do you use now to evaluate student licensure performance potential? Are you using, like we did, overall score in the curriculum? Are you using maybe a couple of practice tests that are supposed to be very similar to the boards and checking student results on those? Whatever it is you're using, make sure you take stock of what metrics you have right now. One of the things that we did, and that I think is one of the more common ways to do this sort of evaluation, is to use a regression analysis. And regression analysis can sometimes be very, very useful. It's going to give you, how well does it really correlate, doing well in your curriculum versus these board scores? How related are they? But sometimes it can hide valuable data because in a massive data set, there can be sub-trends, so to speak, that a regression analysis of the whole might not point out to you. When you take a look at this and you're designing your category scheme, you're identifying your different criteria that might make your curriculum unique or might be unique about your licensure exam that starts to point you in the right direction, think back to that predicting scores overall versus predicting who will fail, and make sure you know what you're looking for and design your study appropriately. So once upon a time, we did this. We were facing a lot of challenges. We took a look at our board results year after year, and our outliers were becoming more and more consistent, and they weren't outliers anymore. Every year we had a couple unexplained failures, or people who didn't fit our normal criteria for students who were at risk were still failing. And that happens once every 5 or 6 years, that's one thing. But when it starts happening every year, okay, what's going on here? How is it possible that students who are well outside of what we would ever have identified at risk are failing? There's too much noise in the signal. Sometimes, especially with the push in today's curriculum to have more assessment, to have integrated curriculum where everything is together and whether it's case-based or whether it's organ system-based, integrated curriculums put a lot of noise in that signal because now there's lots of things being sample tested over a long period of time instead of one course giving you a huge amount of assessment data on a student over a shorter period of time. So there's a lot of noise in that signal. Now that's still, for most experts' opinion, the best way to educate, but it doesn't always give you the best data to work with as far as identifying students who are at risk of failing the boards. The metrics that we were using were producing groups that were just too large for the resources available. If we were just to look at the range of students covered by our failures, it was 40, 50, sometimes as high as 60 students fell into the range that our failures fell into, meaning when we looked backwards at previous years and we said, all right, let's plot out who failed, they fell over the bottom 50 ranks of the class or the bottom 60 ranks of the class. And going forward, it was really hard to say, all right, we're going to intervene in a really meaningful and extensive way with 60 students. That's just not really possible. Nobody's got those kind of resources. The second part of all of this, as we started to dig through these things and look at different data and try and change the way we've traditionally thought about this, was that we had to convince the faculty members that new data isn't voodoo. And you have, I think, at every institution, some people who are resistant to change, or who, you know, for 30 years we've been using total score in the curriculum to predict students who are going to fail, and that's the best way, and that's the only best way. Well, 30 years ago, we didn't have access to the type of data analysis we do now. We couldn't track things the way we do now. And so convincing faculty members to take a look at this data and use it was also kind of a challenge as we went along the way. We started looking at our unique characteristics, and we looked at our licensure exam first, and they were obvious. I mean, I think anybody who's involved in medical education, or, you know, likely nursing education as well, knows that the key features of a licensure exam aren't necessarily hidden, but they were interesting to us as areas of things that we could start to study. Every single question on our board exam, USMLE Step 1, was a clinical science vignette format. So that there was no factoids about this or that. There were no just recall this information. Everything was set up in a vignette format where a patient case scenario was presented, and students had to, you know, pick out information from that and answer the question about the case. Usually, because they were doing it in that patient case scenario format, they were testing higher levels of Bloom taxonomy. They're not just doing that knowledge level, that initial first tier. They were getting up into the application and synthesis of information, where you had to not just take a look at a question and recall something, but you had to recall a few pieces of information, apply them to the case, and then take a few steps from there. Maybe what you had to figure out what the diagnosis was and what the most likely treatment was, so that you could answer a question about a side effect. Those sorts of things. Additionally, exam performance on the exam was broken down for both our school and our student into 20 subject areas. The school received an overall aggregate report of performance in those 20 different subject areas, and students got individualized reports over those areas as well. We kind of keyed in on those 3 areas in particular for things that were unique and distinct characteristics of our licensure exam that we were going to try to use to start to highlight performance internally and use that internal performance to predict how students would do on the licensure exam. These unique things were not reflected in our curriculum, and that was one of the keys. There was discrepancy here. You can't just start from day 1 of medical school and teach only in vignette style. It doesn't work very well, because they have to learn things first. You have to make sure they've learned it before they can start applying it. So as nice as it is for the boards to be able to do that unique style or that single style exam, it wasn't really realistic internally. And so when we looked at our exams, they were most definitely not exclusively vignette style. They had lots of recall involved in the exams, and eventually we found that it was a very small portion, and I'll show you exactly the portions later, but a very small portion that was actually vignette format. Lower levels of Bloom's taxonomy were much more frequently represented because, again, you can't just jump to the top of the pyramid and test from there. And when I started, and when we started digging into these things, at that point the students were receiving no breakdown of performance post-exam on any subjects, topics, learning objectives, or anything else, let alone specifically the board ones. They got their score, you get your 80, your 75, your 95, whatever it might be, and you moved on. So here's what we did. Every single question in our curriculum, we went through and decided to tag it with 4 question types. And the question types weren't just question types. We kind of married it to a level of Bloom's taxonomy. So these categories weren't necessarily something that, you know, we could pass out to other schools and say, use these, because they were very unique to us. But what we decided on was 4 different question types, where it was either a recall question married to the knowledge level of Bloom's. We had an interpretation analysis style question that was married to kind of those middle levels, and then our vignettes were actually broken down into multiple levels as well, and I'll show you those here in another slide. One of the questions were also tagged with between 1 and 3 of the 20 or so subject areas that the licensure exam reported on. So those 20 subject areas that we received feedback on as a school, those all became categories, and they all became, every single one of them, at least one was tagged to a question, but sometimes you'd have a cardiopathology question or a cardiopharmacology question where it hit multiple areas of the subject exams or the subjects on the licensure exam. So we would tag those as well. Every single one of the questions that was put in our exams got at least one of these. Then we used longitudinal analysis, and we started tracking these things. The longitudinal analysis allowed us to track performance on categories across multiple exams, eventually across the entire curriculum. So we could see not just on an exam-by-exam basis how students did on these things, but in total, how were students doing on each of those question types across hundreds or even thousands of questions. Here is a sample of the different categories we used. So, like I said, the question types are broken down: recall of factual knowledge, interpretation analysis of information, and then application basic science vignettes or clinical science vignettes. We found that even as we looked deeper, basic science vignettes existed where it was still that same case scenario, but it was just a fancy way to ask what bone in the arm was something, or what was the action of this medication. So it wasn't really true clinical science, but it was a vignette surrounding more of the lower level and basic science level type facts that they needed to know, but they were wrapped into kind of a pretty package. The actual clinical science vignettes were the ones that really more accurately reflected the boards, and that there was multiple steps required, multiple levels of understanding required. Then you can see there the different subject areas that were broken down by the USMLE, and that we then tagged to all of our questions. So here's an example of an individual student performance, longitudinal performance summary. And so you can see there on the side the number of questions that each student took in each area. And so by measuring across, we were able to get up to hundreds and hundreds of questions in those question type categories. Same thing in our general areas, which was another thing that we added in. And then a breakdown of every single USMLE subject area. Showed us lots of things. It showed us things on aggregate for our entire college. It also showed us things for individual students. We were able to spot trends in that performance. So the setup. After we categorized all of our questions, we had 3 years of category data available to us. One of the nice things that we found is we traditionally went back and looked. We had a lot of data available to us because we'd been using ExamSoft for a while. And so if you've been using the system for a while, you can get that past data. But when we traditionally identified students, we used their total scores for Med 1-2. Usually any student with an average of around 80 to 81 and lower were at risk. And that totaled 40 to 50, and in some years even 60 or so students. That was true going back as far as we could look at the results. So we had some, historical data from our traditional metrics to take a look at, but we also, as we went through and categorized, we had multiple years of category data on these new things that we identified. We had those to look at as well. We didn't have to wait for the future to come along and wait for future years students to take exams, because we could get the data going backwards. So when we did the analysis, in the analysis, we took a look at that Med 1-2 total score, and we compared it to every single category that we had created. We compared Med 1-2 total score to score on USMLE Step 1, and we used the longitudinal performance in every category to compare each category to performance in USMLE Step 1. The initial analysis showed really strong relationships between both our traditional metric and performance with the clinical science vignette question type. Others had some pretty decent correlation, but it wasn't as high. These ones were within hundredths of a point of each other, but the Med 1-2, our historical method, was actually still marginally stronger. So we started to look into that a little bit closer, because now that we had found something that was nearly equal to our Med 1-2 total score, we wanted to see if there was other ways we could slice this data and take a look at it that would provide us better results. So we went through, and due to that category performance being linked, we were able to get that data and look at it in different quartiles. And we started looking at the bottom quartile, the second quartile of the Med 1-2 total scores, and those for the clinical science vignette category. What we found was, when you looked at just the bottom two quartiles, the category performance on clinical science vignette was actually significantly better at predicting how students were going to do on USMLE Step 1 than Med 1-2 total score. But when you got into those top two quartiles, something was happening there where that category performance wasn't as good, and the Med 1-2 total score was actually better again. And so depending on what you were looking for, and this goes back to my previous slide, of are you looking to predict overall the best way to predict what score a student is going to get, or are you looking to best predict who is at risk of failing? Because if you were wanting to best predict a score and you were looking at the top half of our students, it would be Med 1-2 total score. But if you were looking to predict who is most likely to fail, and let's face it, that's who we worry about most frequently and what 90% of our resources get spent on, then the category performance was a much, much better predictor. So when we took a look at that, and after we looked at the regression analysis, we just ranked the students very simply by their Med 1-2 total score and their USMLE failures. And like I said, that's 40 to 50 ranks that the failures were spread out in. But when we started doing that by clinical science vignette category score, each of the 3 years where we analyzed the data, all the failures fell into the bottom 10 or 12 ranks in that category performance. Now all of a sudden we've got a much tighter field. We've got a much smaller group, and this was consistent over those 3 years, that it was never outside of the top 12. In fact, one year they weren't outside of the top 3, or excuse me, bottom 3. They weren't outside of the bottom 3 in clinical science vignette category performance. So now that we had a tighter field, we could start to look to do different things with that. As we started to go through our conclusions and look at what was going on in our curriculum and this data and this tighter field we had, we saw that we actually had a 3.5 to 1 ratio of recall to clinical science vignette questions. And so that's where the noise in our signal was, that there were so many questions that could be answered by memorization, and they were so prevalent on all the exams compared to the clinical science vignettes, that students were skewing their score. They were doing great on those recalls, performing as high as 85, 90, 95% on recall questions, but struggling with the clinical science vignette performance to the tune of maybe 60, 65%, 70%. So there was a huge disparity, but we weren't seeing it in their final results simply due to the ratio of questions and how they were represented on the exam. There was an average difference when we look at the students who specifically failed the boards. There was an average difference of 15% between the two different question types. Curriculum-wide, we looked, and there was a 4% difference. And again, I think that comes into play with that top half of the students. Actually, some of them performed better on the clinical science vignettes than recall. And so you started to see that margin shrink when you included the entire class, but still curriculum-wide, there's approximately a 4% difference in performance between the two different question types. So we started setting up intervention. Once we had this group narrowed down and we said, this is our group, we are confident, we've got years of data now showing us this is the group we need to intervene with, we started to look at how to do that. When it was 40 to 50, deep intervention was just not effective. So the lowest 12 performers were offered extra academic counseling, tutoring, resources. We brought them all in. We shared with them that we've been studying this. We said, hey, look, but we've been trying to figure out how to predict who's going to fail as best we possibly can because we want to help those students at risk. And by every metric we've been able to look at, you fell into this category, and we explained it all to them. And we offered them counseling help where they could meet with the academic counselor weekly during their board prep time, and that the academic counselor would actually use the data from those subject area categories to help them create customized study plans. While the subject areas didn't actually give us a better way to predict, they did give us a very useful tool in actually showing students in an integrated curriculum, especially where there is no more pathology course and there is no more anatomy course, where it's all integrated. Those subject area categories longitudinally gave us a great indication of where students need to spend extra time and where they were okay, so that when they were divvying up the time, the precious time they had to study for the board exam, they would be able to use that. And so we actually had the academic counselors sit down, create customized study plans with them. We created group tutoring sessions, one-on-one tutoring sessions. We got peer tutors for them. We had faculty tutors for them. And we offered them extra resources, question banks, courses with external companies to do board prep classes, things along those lines. And we offered it to all of the 12 lowest performers because we could afford to invest that level of resource in a number that was narrowed down for us. So what happened? In year one, of the 12 students that were offered all those extra resources, 10 of the 12 accepted and 2 declined. In year two, the exact same thing. 10 of the 12 accepted, 2 declined. Sometimes they just wanted to go home to their home state. Maybe they're an out-of-state student. They wanted to go home and study, so they didn't want to stay around for the study period and work with our people. Sometimes they were just thinking they didn't need it. They thought that they had blown off exams in our curriculum to work on board prep this whole time, and that's why they were performing low. Variety of different excuses, but for whatever reason, each year 2 declined. Both years, all 10 of the students who accepted our intervention passed. All of them, 100%. And unfortunately, fortunately for the case of this study, but unfortunately for those students, the 2 who declined each year both failed. So now we were really not only able to predict who was going to fail better, but we started to be able to prove that our interventions worked, that even 2 full years into our curriculum, after they'd gone through all of our courses and everything we had to offer, at a point in which you would say normally, well, they either get it by now or they don't, and 6 weeks or 8 weeks of board prep time isn't enough to kind of turn that ship around, what we were showing was that it actually was. That there was enough of a foundation there that if you used targeted data that really knew the ins and outs of the strengths and weaknesses of these students, you could intervene even at the last minute and have success and help them pass. In addition to those subject areas that we were using, we started using the question type performance to change how they were studying and change how we would intervene with them. Students who were, doing better with, vignettes and worse with recall, as we expanded this out to the rest of the class, we would give them more case-based things to study. Students who, or excuse me, I said that backwards, but we would give them, we would point them more towards the recall and some of the normal processes and the basic information that they needed to brush up on. But the students who struggled with vignettes, that's who we would give the case-based things. We would turn all of their studying into case-based studying, because frequently we'd find they were just doing simple things like rewriting their notes over and over and over again. And that wasn't going to get them where they needed to be. So we had to not just change what they studied, but how they studied it. Eventually, that data was provided to all of the students for use in their own study. We couldn't intervene with them, we couldn't set up study plans for them, but we wanted to release all this information to all the students, and we would usually do a half-hour session where I would go in and teach them about these reports and just say, hey, this is what this means, take a look at this when you're making your schedule, when you're making your plans, try and use these things. I'm going to jump back here for just a second and stay here for a moment. When we did that, one of the things that we found was that the students actually, on the whole, were able to use this and be self-directed learners better because we gave them the data. And with that data, and I think it might have cut off at the bottom of my slide here, but with that data, what we showed was that our entire average as a school went from about usually around 1 point above the national average every year to 7, 8, 9 points above the national average every year once we started providing this extra data to students. So while we were intervening and fixing and using all our resources really on those students who were at risk of failing, as on a whole, we were able to have success as well by letting students direct themselves and giving them the tools they need to direct themselves better. Because without the tools and without the guidance and direction of that data, they weren't doing as well with it. So where do we fit in? The tools you need. Where ExamSoft fit into this entire equation was none of it would have been possible if I couldn't categorize my questions in really an unlimited number of ways. Because when we started, we didn't know which category was going to work for us. So we would sometimes throw 10, 12, 14 categories on a single question. And so the ability to unlimitedly categorize every single exam questions and get personalized student post-exam reports and aggregate post-exam reports on the entire class performance was really, really valuable in helping us track all this stuff down. In addition to those post-exam reports, though, longitudinal analysis of category performance was key. There's no single exam that's going to really point you in the right direction when you're trying to outline a really underlying current. A theme that runs across all these different things is most likely going to be what ends up helping you predict. And you can't look at individual exam performance for that. Being able to look longitudinally and analyze category performance across every single exam quiz we gave in the curriculum was very helpful. The retroactive data as well, being able to, since we had already been in the system, just toss our categories on there and have the system go backwards for us all the way back to the first time it was used and get that data for us to compare to. We now had 3 years of data to compare, whereas most studies, when you're going to do this sort of thing, you start with, okay, we've identified this criteria, now let's watch and monitor it for 3 years, and then we can do analysis. Because we've been using the system for a few years, so if there's any clients on the line today, if you've been using us, you have the ability to go backwards, get this data, so that you can try every different variable and combination you can think of right away, figure out what works, and immediately start using it going forward instead of having to wait years and years for this thing to play out. Also, the Student Longitudinal Progress Dashboard. I'll show you what that looks like in a minute. As a result of the value of all of this, one of the things I begged ExamSoft for when I was still a client and that we released back in October was a Student Longitudinal Progress Dashboard. Now students can log in, and instead of you having to produce a report for them and send it to them about their progress across exams, they've got a dashboard where they can actually see that all live updating every single time they take an exam themselves. And I'll show you what that looks like. Here's an example of that post-exam report. Again, this is just the subject area section of the post-exam report. And you can see there's so many different questions from different subject areas represented on an integrated exam that these sorts of things don't necessarily mean anything on an individual basis. But when you look at them across in a longitudinal report like this, it means a lot more. And as you look at this report, you can see that the number of questions is starting to build up across the exams. The students can choose which courses and which assessments they want to include in here. So let's say they change their study pattern after a few exams when things weren't working for them. They can test out how that new approach is working for them. Did changing to case-based really help improve their performance like they thought it would? So this is something that's live, and every single time the students take an exam, these little sliders here are going to update, and they're going to show the class average as well, so you can get a comparison performance. Maybe at a certain stage of the curriculum, there's going to be things that they just aren't ready for yet. They're intended to be struggling with it yet, because later in the curriculum is when that all comes together. Well, by having that class average there, they can take a look at that and know that it's something they don't need to worry that much about. But if they find themselves severely below some of the class performance, that's all of a sudden something that they want to take a look at. They know to start seeking out help, seek out a peer, seek out academic counseling, come see a faculty member, whatever else. And so these things being available along the way also start to help things. So with that, what questions do you got? Throw them at me.